Okay, the next section is presented by Professor Renuka Iyer. She is the Professor of Oncology at the Department of Medicine at the Roswell Park Cancer Institute at Buffalo, New York University, in New York. And she's going to share with us about the guidelines for caring for patients receiving chemotherapy. Okay, so Professor Iyer, please.
Thank you for having me, and thank you for the introduction. These are my disclosures. So the overview of what I wanted to cover was how we're treating bile duct cancer right now, the common toxicities that you encounter, just very briefly the GEMCIS guideline from the NAB, and the problems just sort of building on our previous speaker, managing cholangitis, some guidelines that we came up with from the Delphi panel, a biliary emergency card that the Cholangiocarcinoma Foundation has developed. It's on their website, how to access that, and then just a little bit about the future. So this, you know most of this, the incidence here is much higher, so you probably see this a lot more than even we do, but these are just the incidences and numbers from the United States. And unfortunately, even though we know that they have many molecular signatures, and down the road, all of those options may become standard of care very soon, maybe next year, 2 years from now. But for right now, we still have only palliative GEMCIS as first line. And for second line, I don't know how it is here, but at least in the US, we're using FOLFOX or something with 5-FU. I'm guessing you're nodding, so you probably have pretty similar practice patterns. And so in this big phase 3 study, the ABC02 study, they included performance status patients 0, 1, and 2. So I just want to point that out, that there were some people who were already quite sick to start off. And also, it was only about 11 or 12% of patients, but it's just something to know, because when you're starting to manage toxicities, if they're already pretty sick, that's something to know. And just a few things when you're talking to the patients, they sometimes are asking, what is the survival, what is the prognosis? And I think after first line therapy, median survival is 11 months overall, but with second line therapy, the median progression-free survival is only 3 months. So especially if they've not had any response to GEMCIS first line, the chances of good response with the second line are not that great, because you talk to the patients much more than even the doctors do. So if the patient is sort of deciding, should I do more therapy, should I not, those numbers are good to have in your mind when you're talking to the patients if they are ready to hear it, And then other options, now we're looking at GEMCIS and Abraxane. The talks are going on in the other room right now. A little bit more toxicities, but that could also come in the future, something to be aware of. And all these new precision medicine things, they all have a little bit unique toxicities, small things, but they're all less toxic than GEMCIS. So on GEMCIS ABC02 study, which was mostly Western population, what were the main toxicities, that you would encounter with these patients in the first place? So mostly it was count problems, with low blood counts. You can see a little bit more when you give the combination. Fatigue was very common. Nausea, vomiting was also there, not super high, but some of that. And biliary sepsis and infection, we just heard a talk on that too, was also present of any type of infection, was about 18%, 19%. I also want to point out that liver function abnormalities were seen. These patients already start out with liver function abnormalities, but they were actually seen more in the GEMCIS, more in the GEM arm than in the GEMCIS arm. So that's something I wanted to point out, and we'll talk about that. Also, the GEMCIS study was done in the Japanese population. So BT22, they saw a little bit higher number of WBC counts. We saw in the other study was like 20%. Here, if you look, the grades are higher, but I think it's because they were mandating that the people will go for blood work in the off week. When you do 2 weeks on, 1 week off. In the other study, they were not doing blood work in the off week. So if you check in the off week, then I think that's the reason why it was higher. I don't think it's only because it was Japanese patients. I think it's because they were checking in the off week, But it is known that gemcitabine can be a little tougher on Asian patients for bone marrow. It's known. but I think some of it is from the extra blood work. And then, nausea, vomiting, the fatigue got scratched. But fatigue was there quite a lot, in these patients was quite a bit. And I don't know how much of that is from the low counts. Sometimes they're tired when they're neutropenic. And here they did not report cholangitis, as a thing, but they wrote fever. If you look, all grades on GEM-CIS and all grades on GEM. So this also, some of the fever could be the GEM fever, but some of it could be infection fever, So just so you know, like, what is the chances? What side effect am I really going to see? So what the Nursing Advisory Board did was to make a list of all the things that we want the patients to know before they start the chemo, if they're on the chemo, so that they make sure that they know, do you know what cancer you have? Do you understand what this disease is doing? It's causing obstruction, this. Explain that to them. And they should be able to report their symptoms. When something happens, they phone someone, they go to the emergency room, they should be able to describe what problem they're having, what medicines they're taking, and even the family should be aware, because the patient is too sick, then other people should be able to help them. And then the intervention was to see, do you have, when you're documenting in your notes, you want to make sure you write, are they allergic to something? Because if they have to get antibiotics, you want people to know what they're allergic to. And also just what are they aware of? Like, sometimes I've had a patient saying, I have a stent, and then you look, he has the PTC. So they sometimes don't know like exactly what they have. So sometimes you have to talk to them and say, this is not a stent, this is a PTC tube, this is a little different. Sometimes they don't realize, what they have. So we have to tell them. And sometimes they don't know, is it draining inside and outside? Then I ask them, what color is your stool? If they say it's brown, then I say, well, then it's draining inside and outside. Because if it's only draining out, then the stool is light. Or if something has changed, then to be able to ask them, what was it before? What is it now? Oh, it was only draining through the tube. Now it's draining around the tube. That means it's leaking, So just to help them understand that. And then interventions, to basically have them record their fever at home so that they're aware on the day of gemcitabine, you'll get a fever, it can be high, you may have chills, but that is a drug fever. So on that day for 24 hours, you can take Tylenol or, Motrin or some ibuprofen or something. So that kind of education is necessary. And also when they call you and say, I'm having nausea, you have to ask them, did you take your nausea medicines? Sometimes they don't realize they can just take it, So the simple stuff. But how to manage these side effects? That's what the main thing is. One is to know what it is. Because in my medical school, they had taught me your eye can only see what your mind knows. So if your mind doesn't know what it is, then you'll see it, but you won't know what it is. So I think that's good to know. So for low counts, mostly what we're going to do is do dose modification. So the dose is going to be a little bit less for the next round or for that round. And for fatigue, ASCO, there's the organization in the US, ASCO, you are all familiar also. I'll put another slide, they did some studies to look for fatigue, anemia, simple things, you fix that first. If they're tired because they have infection, then you treat the infection. But if they're tired truly because of chemo, then they found that exercise and family support can actually be more helpful than even medications. Because, we give them low-dose steroids or something to boost their energy. Actually, exercising and moving around can be more helpful. For nausea, we always send them home with the nausea medicine. We want to make sure they filled the prescription and they took it. And then for biliary sepsis and infection, they have to know to recognize that you have an infection, call the doctor right away. So that's sort of the key things. So this is the thing about the cancer-related fatigue. It's far more prevalent than we all realize, because sometimes in the clinic, at least I know for like doctors, we just talk about the scan much more. We talk about the fatigue much less, and patients also don't bring it up with us because they think, okay, her time is so precious. Let's talk about the scan because that's important to them. But this is important to them too. So I think that it's very important that after they finish their treatment, regardless, looking at these lots of clinical trials, they did a lot of clinical trials. They found exercise, psychological intervention. Sometimes they don't do anything because they're afraid of going up the stairs. And then when you tell them, why don't you try, go with somebody, go small distances, then they build the strength, then they do it. Otherwise they're tired because they didn't do anything. They're deconditioned, So that's something to remember. And then this was another thing. Last year at ASCO, they presented like what are the big discoveries of the last year, like 2018, what are the big findings? And this was one of them, that when patients are engaged in their own care, then they have better outcomes. And they had different apps and places to report their symptoms. Then they talk to one another, then they realize, because a lot of them, they're not feeling good and they don't know what to do about it and they just sit there. So sometimes just having that support, better quality of life, quick intervention, then you have less ER visit. So what is another problem, one infection, just to sort of build on the previous talk. The problem with this little cartoon, I know it's like your liver scan, you don't have all your ducts in a row, is because these patients, to make them to get the chemo, their bile duct has to stay open. It has to keep working, because otherwise you cannot treat them. And what happens is that in the GEMSIS study, ABC, 45% of patients in each arm had stents. And if you look in the FOLFIRINOX study for pancreatic cancer, because I know many of you also see pancreas patients, 25% of those patients had stents. So that's something to be aware of. And unfortunately, I literally just cut this out from the article, from the New England Journal article. This was Dr. Valle's, conclusion. Infection rate in this study was 19%, and abnormalities in the liver function were more common in the GEM arm than in the GEM-CIS arm, and his feeling was that it's because the GEM-CIS was more successful in keeping the bile duct open, that's why the liver function stayed good. The GEM was not as good in controlling the disease. But radiographic response was only 20% on GEM-CIS. So even though there's not big radiographic response, it's enough, because that's what he's describing, this physics like kind of law, even just a little difference in the diameter can make a big difference in the flow. And if it's flowing, it's less likely to get infected. So I think that's really the take-home message here, is that even though GEM-CIS, when people say, oh, will it shrink the tumor? You say, not so great, but it'll shrink it enough to keep that bile duct open and flowing. So that's a good, thing to remember. And why are these patients at risk? It's not just the stents, it's also the PTCs. Even those are like high risk. And I wrote GEM-CIS because, those are, the risk was to 19%, infection rate. But see, those are the best of the best patients who go on the trial. The real patients that you and I see, on an everyday basis, these are the kinds of patients we see. So that risk is actually kind of higher, and many patients are more at risk than we realize. So what is the care when you see someone, you already just heard it, sorry for the repetition, fever, chills, change in any drainage in the tube, those are the things we want to look for, liver functions, white cell count, and we want to look at the scans, make sure they don't have an abscess, and you want to talk to the primary care team. Sorry. And so what we did was we worked with the Cholangiocarcinoma Foundation, and you know how when they get cardiac stents, they go home with a stent card? We came up with a card that's on the cholangiocarcinoma.org website. So all your patients can go there, or you can go there for them if you have a printer, and then just fill in the information. And all the information that they ask for is, what is your name, what kind of stent do you have, plastic or metal, and so on and so forth. Who's your doctor, your surgeon, your medical oncologist, which hospital. So there are 3-4 different phone numbers all in one place. So this way, they know for the patient instruction, if you have any of these symptoms, go to the doctor, go to the emergency room, take this card with you, and when you give the card to the doctor, make sure that they read it, because then it looks like it's a physician-to-physician communication. It doesn't look like the patient is saying, oh, give me antibiotics, because the doctor may say, why should I give you antibiotics? So, but when they see it like it's coming from the Cholangiocarcinoma Foundation, and they also can go to the website, scan this, go to the website, and it lists, if somebody is new, maybe they just started to practice. They're not so familiar. Here, maybe much more than US, but still. And so it's tough sometimes, because these patients, they don't have like high white cell count because they're on chemo. These patients already have abnormal liver functions, so somebody doesn't know the patient's old labs and they go to a different hospital, they're on vacation or something. Then they think, oh, they must be high bilirubin because they have cholangiocarcinoma. Then you have to say, no, he's on chemo. His bilirubin was 1 yesterday, and now it's 5, so that's a problem. That's not just supposed to be there. So that's very much, hard. And as Sue said earlier, even though the plastic stents are supposed to last like 3 months, 2 months, many times, you end up hearing that this is the 4th time. I think I need to call somebody else. I'm getting a different service department to make my stent to work because it's never working good, It just happens. So unfortunately, we have so many guidelines for like rash, rash from chemotherapy. So many, it's 15% of people get rash. And there are so many publications for rash management. For hand-foot syndrome, so many publications. And for cholangitis, like actual management, there's no publications. All the publications are incidents, how often it occurs, what is the severity. Okay, how do I treat it? Like, tell me, like more, like on an everyday basis. There is nothing. And so that's unfortunate. So we all need to get together and put some of that together so we have more evidence-based, guidelines. So what we did was we got together, and there's something called a Delphi process, because it's hard to do a trial where you open somebody's stent and don't open somebody's stent. That's not ethical. You can't do those kinds of studies. And so what they do for that kind of situation is that they get a group of different doctors, because there are different practicing doctors, nurses taking care of these patients, and put them all in one room and say, in every scenario, what would you do? What would you do? What would you do? Where do you rank more weight? To the liver function, or to the white count, or to the fever, like this. And so that's what they did. We collected all the available literature, picked panelists from UK, US, different places, and then we developed 480 different situations. High white count, low white count, normal white count. High bilirubin, low bilirubin, normal bilirubin. Like this. We went on and on. And through that, we rated all of these things before. Then we went to ASCO. We rated it again. And then they found where is their consensus. And these are all the things that we use to guide us. Good performance patient, will you admit or not? Bad performance patient, will you admit or not? Like this. And what we found was that this was the consensus, that everyone was in agreement that if bilirubin is elevated, it's appropriate to change the tube or stent, you need to go and flush that tube or do something to change it. Inpatient antibiotics, yes. High bilirubin and fever, yes, you will admit that patient. Most people would say yes. Maybe appropriate to admit if the patient is not having fever but has high white count, or if the patient is neutropenic. So you get the point. And this we presented at ASCO, as well as at the Cholangiocarcinoma Foundation. We're finalizing our manuscript, so we'll hopefully this year have it published. It's been in my to-do list. And so this, you can find this on the website for ASCO as well if you wanted to find it right now. So another thing that helps, we spoke about aggressive treatments, but also sometimes good communication and coping tools are necessary, because sometimes it's end of life for some of these patients. So helping them understand when they've had enough, like I cannot do this anymore, or it's good to have a good conversation with patients. So there have been studies on that as well that show that then they have less doctor's visits, they're more productive, they're more happy with their goals of care. So my takeaway here is that moving forward, there will be more options with targeted agents. Immunotherapy is coming on the horizon. So there's going to be a need to have meetings like this and talk about how are we all managing, like a panel, like, okay, how are we doing? And also to educate our patients and the caregivers and everybody in the team so we can all recognize the side effects. It shouldn't be only one person knows and nobody else is aware, like what to do when that person's on vacation. And we, between the Nursing Advisory Board, the Delphi panel, ASCO supportive guidelines, Tokyo guidelines, there are many such things that are coming, all newer, they're coming. So we need to continue to use them. And then we have to measure, like, what is the impact? If we use it, what happens? Is it better? Is it worse? How much cost saving is there from doing this? We need to do that. And we need to start publishing this so that tomorrow when we do a new clinical trial, in the supportive care section of any clinical trial, we should say, everybody should get this, like this, like this, For certain things like management of hypertension with Avastin, like it's very clear, like grade 1, do this, grade 2, second incidence, do this, do this. For us, we're so far away. So we have to publish so people will use our reference, to do our work. So we look forward to doing that with you. But at the end, all of what we're saying is good, but at the end, we should always be looking to see, is this patient eligible for our clinical trial? Because you'll hear from Melinda tomorrow. The hope is really for people who can get on a trial and get something bigger and better than what we have today. Because the truth is, everything I'm talking about is just to buy a little bit more time. But what we really want is more Melindas. We want more people who go very far, very far. So that's our big hope. And this was the nursing advisory. This is an older slide. This was the team that made that guideline, the one that I just now showed you. And these were all the physician experts on the Delphi panel. And with that, thank you so much for having me and the organizers. Thank you.